procedure?
I do it. I mean, very frequently. In fact, like once a month, I do it.
Best person to talk.
Can you see me? Yeah. So, good evening, everyone.
Dr. Shilpa, you are live. You can start, please.
Good
Thank you,
evening,
sir.
everyone. At the outset, I would like to thank Dr. Padmapriya for joining us today for this important session. I would also like to thank Dr. J, who, in spite of it being a weekend night out for him, he still came on to log in and do all this live program. So today's topic is a very important topic, as Dr. Padmapriya already mentioned.
Yeah, I had to justify so much, madam, to come outside just to go live. My
Sorry,
justification has been more than the tech topic curator now. Okay, I'm going
I'm
back.
so
You
sorry.
continue.
Yeah, sorry, sir. Thank you, sir. Ever grateful. Uh, so
Devascularization.
yeah, he just like, please, I'm so sorry. Today's topic, I think, is a very relevant topic in today's generation, especially the new generation of obstetricians who are coming out. I think this uterine devascularization has to be known by all the postgraduates and also all the obstetricians, even if they are doing one delivery in a year, because this is such a lifesaver. As
Yeah.
we all know, postpartum hemorrhage is one of the most important cause for maternal deaths, and 90% of them are preventable. So here we are talking about the importance of the time when we come across the postpartum hemorrhage, especially atonic PPH, and when we want to reduce the blood supply to the uterus. So without wasting much time, I think I will go to the surgical aspect of it. The medical aspect, I don't think we need to discuss at this point in time. Let us just go to the direct topic. I'll share my screen. Can you see, madam?
Yes, madam. Yes, ma'am.
So this is the first video which I will be showing. So this is the uterine artery ligation. You can see that I have done the cesarean and I have sutured the uterine incision also. I have exteriorized the uterus because I want to ligate the uterine artery. This is for the demonstration purpose, though the uterus here is well contracted. So you can see that I have taken a 2347 vicryl round body and I am taking the bite 1.5 centimeters from the, can you see my arrow, madam?
Yeah, I can see.
So this is the lateral wall of the uterus. So the first bite which I took was about 1 to 1.5 centimeters at the level of the UV fold of peritoneal attachment. And I go anterior to posterior. And the assistant, as you can see, is stretching the uterus onto the opposite side. Here I am ligating the left uterine artery. So from posterior to anterior, I come through an avascular area in the broad ligament. And I will tie the knot. So this is vicryl round body 2347. And also one of the important thing here is like I have put my left hand into the posterior leaf of the broad ligament so that I know where the uterine artery is, one, to check for the pulsations. And second thing is once the needle comes out posteriorly and when we are taking the bite in the broad ligament, I don't want the omentum or the bowel to be included in the bite. So the finger, the index finger, which we keep in the broad ligament posteriorly, will help us prevent inclusion of any of the other structures. So I take about 3 to 4 knots and then I cut it. So then I observe for 5 to 10 minutes whether this will control the bleeding. And if it controls the bleeding, then I don't do anything much. If it doesn't control, then we can take another bite 2 centimeters below this. So I will show you another video. So this, as I described, this is the video showing the uterus is exteriorized, and I have taken the same suture material. Here you can see that anterior to posterior, here the lateral margin of the uterus is here. I have taken the bite about 1.5 centimeters. I have included the peritoneum here, which doesn't matter actually. And I have thrown the knot. The knot has to come on the myometrium and not in the broad ligament, because this will keep the knot secure. So some people can advocate that we can even include the round ligament so that the tearing doesn't happen, but usually I don't do that. And as you can see here, so I put my finger, you can see the finger which is protruding here. This is my finger, which is the index finger of the left hand. So here the bleeding which was there, I'm seeing that there is still bleeding from the upper edge of the uterine incision. So I go and take another bite just to include this area of the uterine artery. So here the same thing I do. I take 1 to 1.5 centimeters from the lateral margin of the uterus anterior to posterior, and then come out in an avascular area in the broad ligament, making sure that no structures are included posteriorly. So this is one of the videos. So I'll show you another. So posteriorly, what do we see? So this is the exteriorized uterus. I have, you can see that the bite is somewhere here. I'm just showing that I have taken the bite here, and posteriorly I'm checking the posterior surface of the uterus, so that I know that there is no hematoma, and also there is no oozing. Sometimes the hematoma will be there, sometimes the oozing will be there. If we put pressure, it will stop automatically. So here is another video which you can
So this
see.
is a case of previous cesarean.
So this is a case of previous cesarean, where you can see the uterine artery is pumping from the left angle. Usually when we are trying to extend the uterine incision with our fingers, the extension will be more onto the left side, because we are all, most of us are right-handed, and the uterine, the wall will be thinned out, lower segment will be thinned out, and so extensions are quite common. So you can see the uterine artery pumping here. So I want to ligate this uterine artery even before I close the uterus. So first thing I do is I exteriorize the uterus here, and you can see that I have put 2 Alice to include. Now I have only 1 Alice. You can see how the uterine artery is pumping. So I have put my left index finger into the posterior leaf of the broad ligament, and I take the round body needle and I take a bite through and through. So here you can see that the uterine artery usually gets included, but if it doesn't get included, then one of the ways to do it is like you just take a fresh bite without struggling. So you can see that the pump is somewhere in the left angle only. So hold it a little lower with the Alice, and you can see the pumper. So the same thing, you repeat it a little lower, so that it includes the uterine vessels, both artery and vein sometimes, and this will arrest the bleeding. So now you can see that the bleeding is quite under control now. The pumping is gone now. And if required, we can take similar bites 2 centimeter below. So what I usually do in such cases, as in like when I'm doing a stepwise uterine devascularization, is first I do the one side unilateral uterine artery ligation. And if that doesn't work, then I do a lower one, like 2 centimeter below the UV fold of attachment. I take another one, and then I repeat the same steps on to the opposite side. And if this doesn't work, then I go for the utero-ovarian anastomosis. So this is what I usually follow. So this is another one where there is bleeding in the angle. And usually these angle bleedings are from the uterine artery. So this is only to show the practical steps as to how to ligate the uterine artery in different clinical situations. So, once the anterior to posterior and posterior to anterior is taken, beyond the Alice it should be taken. And now you can see that that lower extension of this uterine incision which was there, that is still bleeding. So I want to take another bite here. So I am pushing my index finger medially from posterior so that the uterine artery comes into the stitch. So sometimes what happens, there will be a little space which may be difficult to take in this round body, that angulated needle. So if we have straight needles, it is much more easier. In straight needles, what we usually do is we go anterior to posterior and then come through and through and then come posterior to anterior. So in this curved needles, it is a little difficult to include the entire vasculature sometimes, especially if we take it from the 1.5 centimeters from the lateral wall of the uterus. So this is the other video. So I will show you the utero-ovarian anastomosis. So if at all, if the uterine artery ligation doesn't really stop the bleeding, so then we go ahead with the utero-ovarian ligation.
Utero-ovarian vessel ligation.
So here the important point that needs to be noted is the Babcock's here, which is held by the assistant, is catching hold of the fallopian tube and also the ovary. So this helps in giving us this avascular area in the broad ligament, and also it helps us in not including the infundibulopelvic vessels. So I have taken the first bite onto the uterine wall just at the attachment of the round ligament. So anterior to posterior I have gone, and then this is the same curved needle, Vicryl 2347, and then I come back in the broad ligament at the same level where I have taken the uterine neck. So here I am tying it onto the uterine wall. I want it to come because it will prevent the tearing. So the assistant loosens the traction onto the fallopian tube and the ovary. And now you can see that the utero-ovarian anastomosis has been ligated. So if the uterine artery ligation doesn't work, then we can do this as an add-on. So we can do it either unilateral or even bilateral. So I will just show. So this is a model of the uterus. Can you see, madam?
Yeah, I can see, madam.
Yeah, so this is the model of the uterus. And you can see the beautiful uterine artery vessels, which are uterine vessels which are running. And this is the UV4, this is the uterine incision. So this is the straight needle with a thread. So here again, I would like to just show you. So here I'm going 1 to 1.5 centimeters anterior to posterior, and then I come back in the avascular area in the broad ligament from posterior to anterior. So once I do that, you can see that the ligature has to be placed onto the uterine musculature to prevent tearing. So this is a very important step, and I think all of us need to understand and also practice this, because I definitely, I mean, I end up doing uterine artery ligation at least like 2 to 3 times in a month, either for the tear in the lateral aspect of the uterine incision, or in cases of PPH when the medical management fails. So I think this is the end of my presentation. Madam, if there is anything, you can just ask me, madam, about. So one thing important is, before we tie the uterine artery, we need to evacuate the clots. And if the uterine incision is not sutured, then we can suture the incision, and then we can do the uterine artery ligation. So someone is asking if we injure the uterine artery by mistake. What if we injure the uterine artery during ligation? So what we need to do is we need to go beyond that and take one more ligature. And usually this will ligate or I think include the vessels. Yeah, ma'am, you can just.
There are a couple of questions that's beautifully demonstrated, ma'am, in your videos, and and since you do such large numbers, coming from you is very important. And can you tell me how much of blood supply is usually, is from the uterine artery, and how much, what is from the ovarian?
So 90% of it is uterine and 10% is from the ovarian.
And which are the situations this is helpful, madam?
So it is helpful mainly in PPH or in cases of, as I told you, angle bleeding, where the angle is difficult to catch hold of, or if it is tearing, or in cases where there is rupture uterus. In such cases, I think we can do this procedure.
What is the advantages of this uterine devascularization?
It's a very simple procedure, and it is extremely helpful in cases where we have already opened the abdomen, and in cases of cesarean especially. The skill required to do all this is not much, unlike in internal artery ligation.
That's my next question. What is your opinion on internal iliac artery ligation?
See, I haven't had to do, I haven't had to do internal iliac artery ligation, because the majority of my cases with PPH have been controlled with either the uterine revascularization or with the compression sutures. So I have done probably like 2 cases of internal iliac artery ligation so far in my career.
Okay, madam. And regarding the after effects of the uterine devascularization, any effect on fertility following this devascularization?
Usually there will be the anastomosis, which will be formed within like 24 to 48 hours. The blood supply will be resumed. So the fertility has not been compromised in any of the studies which I have read, or even in my cases, like which I have followed up over the past 15 years. There has been no problem with the fertility as such.
Okay. What about the menstrual disturbances after ligation?
No, nothing. No menstrual disturbances.
Okay. So after a procedure like this, when do you ask them to plan their next pregnancy? If it's, what is the time frame you give them?
It's the same like birth spacing. I don't think this will alter our advice about changing the spacing of the subsequent birth.
And the outcomes of neonatal outcomes and pregnancy outcomes in the following pregnancy after devascularization, again, because of nothing. You have
Nothing,
not
no
seen
change,
anything,
no
right?
change at all. No change at all.
And usually, how many obstetric hysterectomy have you done, madam, so far?
So far, I have done 3. So there, I mean, it was mainly because they started bleeding after like 4 hours, and then we noticed it. We tried doing all this, but still it was not controlled, and I had to end up, because the place where I work don't have the in-house blood bank. So I think I think the last resort, I had to do the obstetric hysterectomy. But I don't think if we act quickly, and if it is an on-table thing, I don't think there will be a requirement.
Ma'am, and other questions from the, from people viewing. What is stepwise devascularization?
Yeah, that's what I told. I mean, stepwise is like, first we do the uterine artery at the UV fold of peritoneum unilaterally. If that doesn't work, then we do it on the opposite side. If that doesn't work, then we take a lower bite in the uterine for the uterine artery ligation, maybe 2 centimeters below. So first we do that unilaterally, and then if it doesn't work, we do it bilaterally. If this doesn't work, then we do the utero-ovarian ligation unilaterally, and then bilaterally if that doesn't work.
Okay, ma'am. Another question is, how do you manage post-uterine wall hematoma?
Hematoma usually see, like if at all, if we are able to get the uterine artery and the vein inside our stitch, then
Mm.
the hematoma can be like managed. So
The
here
posterior
the
uterine
important step
valve.
is we have to not try to like pass this curved needle without keeping our finger in the posterior aspect of the broad ligament. That is
Yeah.
one thing. Or if at all, if you are in doubt, then I usually what I do is if it is thick uterus, uterine walls, then I straighten that curved needle and then I go through and through, like how I showed you. See, this whole thing has to be like gone through and through so that it comes out from here. And then from the broad ligament, it should come posterior to anterior so that the uterine vessels should be included in the stitch.
Okay. Another question is there any difference between upper and lower uterine artery ligation?
Not really. I don't think so. I mean, there is no difference. It's just like, I mean, where, see the upper one, you can go on doing this, like, as a step by step, like 2-3 centimeters above. So you can take multiple stitches like that in the lateral wall of the uterus. You can take it like 3 or 4 also. I mean, but I haven't done it in my practice, because I mainly have only private practice. I don't work in a medical college where there are more referrals, or unlike Dr. Padma Priya, who is a referral gynecologist for many. So, madam, have you done it? I mean, have you done multiple bites? Have you taken in the lateral wall?
I have, madam. I do take sometimes, the maximum I've taken is 2 to 3, not more than that. Yeah. And yeah, somebody's asked, please demonstrate it. You can go back to the video and see it again. All right.
So
There's
this,
another question. Can we clamp the uterine artery with artery forceps and suture?
I mean, if that's what you want to do, see, finally, what you need to do is you just need to bring in the uterine vessels into your bite. Whether you put a Babcock's, whether you put a artery, whether you put a Alice, it is left to you. So at that moment, your decision making and your, I think the skill sets have to be like 10 on 10, because this is like a PPH is a panic situation. I have had 2 PPH deaths in my practice. So I think this is one of the most traumatizing situation in any of the obstetrician's life. So you have to be like, your decision making has to be like perfect.
Yeah, agreed. Agreed, ma'am. So another question is, if the lower uterine segment is very vascular, especially in preterm LSES, any precautions to take, ma'am?
Not really. Usually it all it all comes with this only. I don't think there should be any difference in this.
Placental side bleeding, how do you manage?
So this will take another session on placenta previa and placenta. I have videos on the opposition sutures and all, which I can show you later.
While attempting uterine artery ligation, when we accidentally go near round ligament, it bleeds like hell. Any ways to control it, madam?
So just pressure will be sufficient in such cases. Like if we apply pressure for 3 to 4 minutes, then it can control the bleeding.
All right. Great session, madam. Any other points you want to add?
Wait, Dr. Padma Priya, Dr. Ashwin wanted to add something. I'll just try to unmute him. Okay.
Yeah, please, sir. Please, sir. So Dr. Ashwin sir is from Surat. Last time he was kind enough to allow me to use his video for, I think, both blades of forceps during cesarean. So I'm grateful to Ashwin sir. So if he is here, I think he will add a few more important practical points which will benefit our members.
Yeah, sure.
Hello. Thank you, madam and Jai sir, for allowing me to give my inputs. It's a very excellent session. Can you hear my?
Yes, sir.
Okay, fine. Just because I am outside, and it's an excellent sessions, nice demonstrations of the uterine as well as the ovarian. Just I want to clarify a few more points. It is one of my important topics I usually teach my PG students because it is a life-saving procedure. I have the excellent few videos, but at present I am outside and only few videos maybe there in my mobile, so not able to upload. But just to clarify, this stepwise uterine devascularization means it includes the multiple points. Silpa madam has nicely told that basically it starts from the uterine artery. If it is only traumatic bleeding like angle bleeding, then it is of course only one side, right or left is sufficient. But if it is a atonic postpartum hemorrhage, then definitely it should be done on bilateral. And one more thing is the ovarian is also give the supply. 10% supplies in non-pregnant, but in pregnancy even more than 10%. So definitely in case of atonic postpartum hemorrhage, after doing the uterine, we have to go for the bilateral utero-ovarian ligations also. And this is particularly when the is from the upper segment, for example, postpartum hemorrhage. But the story for the bleeding from lower segment is different, where there is a role for lower uterine. Is there? Somebody has asked what is upper uterine and lower uterine. Means when placenta is on lower segment, then there are neovascularization. Apart from the branches from the uterine, it also receives the supplies from the vaginal arteries. They are the branches from the other branches of the interior, like superior vaginal artery, middle rectal artery, and all these things. So here we cannot isolate that particular vessels. So madam has rightly said multiple bites, just 1 centimeter, 1.5 centimeter below to the upper uterine. But important thing here I want to clarify is we have to be very careful for bladder dissection. You exteriorize the uterus, give the tell the assistant to pull the uterus upwards, and same time use the reverse retractor rather than doyan, so that it properly retract the bladder properly. And second thing, when you take the lower uterine, your bladder fold should be at least 1 centimeter below to your stitch, so that accidentally you will not injure the bladder, as well as accidentally you will not take the ureter when ureter is enter in the bladder angle. So that two things should be kept in mind. And of course, you have clarified that posteriorly bowel or omentum should not come. So always check before tying the stitch. Once you pass the needle, particularly round body needle, then you before tying check that there should not be something there. So when lower segment bleed, then there is little role for the ovarian vessels ligation, but more role is the uterine ligation and lower uterine ligation bilaterally. And that you have clarified that the stitch, there is a special name of that stitch, is the cervico-isthmic stitch, straight needle. Yes, you have already demonstrated nicely from anterior to posterior, then come back from posterior to anterior. That is very, very useful in case of placenta percreta also, where the profusely bleeding from to take the two good bites on each side, then it makes the pictures very clear, and you can go for the even sometimes in case of placenta percreta, I used to take the bilateral uterine even before putting the incision. So though it is little bit very difficult, may not be possible for all routine gynec, but sometimes for to make the to minimize the blood loss, I used to take the bilateral uterine even before putting the incision on the uterus. But this is not is routine practice, and it is not for the routine for all people, but it is an excellent one. And I have given the thesis to my one resident. Currently it is going on at our medical college, stepwise uterine devascularization once the medical management of the atonic PPH failed. This is the thesis topic, and it is an excellent result. If you immediately put this stepwise devascularization, then the need for the blood transfusion and need for obstetric hysterectomy is very, very less. And I have gone through the literature. Almost it is 80% effective in case of atonic postpartum hemorrhage, stepwise uterine devascularization. So only rest 20% will either need the intranelia or something else. So even another first is the stepwise devasculation. Bleeding is controlled, then fine, nothing is required. And another step, what we do after stepwise uterine devascularization, PPH is continued, we use to compression. So the combo of the stepwise devascularization plus compression stitch. We are using the modified Hemorrhage stitch, so this is very simple compression stitch. And
so that will be tomorrow, sir. Tomorrow we'll discuss about Hemorrhage stitch and Beeline, sir. And
yes.
Yeah.
So the stepwise uterine devascularization, in our experience, even our thesis, we have done more than 50 cases, almost 80% effective in severe atonic postpartum. So it is very good. Everybody can do, even our resident passing from here will do, because we are giving the hands-on demonstrating in high-risk person, you have to take it. So this is very simple. You have nicely demonstrated it. Particularly your model is very good for demonstrating, and it is very useful for all those who are watching this seminar. Thank you. Thank you.
Thank you so much, sir. Thank you for joining and giving your inputs. I thank everyone today for joining us on a weekend for this important session. I thank Dr. Jay for being kind enough to log in and do all this logistics for us. I thank Dr. Padma Priya, who is still in a sari, who has just come from her OPD and asked relevant questions. Thank you, madam. Thank you very much. Yeah, good night,
Wonderful,
everyone.
madam. Wonderful session. Thank you, madam.